Morning, everyone, and welcome to this second seminar that is kind of given in this the research program, the MoBILE research program that I'm heading. So I'm very happy to see that we were almost 30 attendees, so that's great. And when I planned this seminar, I was kind of thinking, what am I supposed to kind of talk about? And then I kind of ended up with this title, which I think is quite interesting. So it's about potential and challenges in digital interventions in 2010, or what you would kind of prefer, some time ago at least, now, and also if we look a bit into the future. And that's because I've been in the field for some time myself. So these are things that I'm kind of reflecting on quite a lot. So what have we done? What have we done, and where are we going? And instead of just talking myself for 1 hour, I decided to invite some of my colleagues. So we have a strong program this morning. So I will start with a brief introduction and a little bit of a teaser to the program. And then we have three presentations. So it's Associate Professor Brian Lawson from KI. He will present internet-based psychological treatment for somatic disorders. And Brian and I also lead a core facility in eHealth at KI, so we know each other from that part as well. And then it's Professor Anna Strömberg from Linköping University, who will present working with patients and caregivers to develop eHealth interventions, lessons learned, and future perspectives. And then finally, Professor Tina Jarsma, also from LiU, using exergaming to improve outcomes in patients with cardiac disease. And I've asked the speakers to kind of present either their research more in overview or a specific project, but also then reflect on these challenges and potential that has been in the past and also in the future. And then we will kind of continue this discussion afterwards, then focusing on these potential and challenges. And I've also prepared a few questions for you in terms of to get the discussion going, but if it kind of people ask questions and you ask questions, that's my questions will not be necessary, but I have a few to kind of get us going if needed. Okay, but first I have just a few initial slides to kind of introduce the subject. And I did my first work in using mobile phones in 2007, and then what we did at that time is that we kind of realized that now we have the possibility to actually contact people in real life, produce real life measures instead of asking questions retrospectively. So we sent the questions that you're now looking at through mobile phones at 9 o'clock each day during 14 days. And that hadn't been possible before when we only had paper questionnaires. So this seems rather simple today when we kind of reflect on what we're doing today. But this is how I started. So this was one of my first studies. So this is what it looked like. It was like not a smartphone, of course, and then we only had a very small Java application to kind of deliver these questions. So that's where I started. And our major problem was how to kind of fit the questions into the screen. So that was the biggest challenge at that time, before people knew how to scroll and before we can kind of put it in another way. Another early work that I did was more analyzing food images, because I also got interested in trying to kind of really capture diet using food images instead of using paper diaries and stuff. So these are a few pictures that we collected in the beginning. Also a bit complicated in that sense that you have to, there will be a lot of images because you have to have an image before to show the food on the plate when you start eating, and then also a picture afterwards to kind of see how much is left. If you're supposed to analyze to quantify the diet, that's kind of necessary. So a lot of work, and participants had to kind of provide 3 angles as well to kind of make sure that we can estimate the volume. And so this was quite complicated at the time. As technology has advanced, this is much easier today, but in the beginning it was quite complicated. A lot of pictures to process and a lot of manual evaluation of the pictures as well. And just to show you some fun pictures that we got, because the first study was in 3-year-olds. So this was one lunch from a 3-year-old, a sausage before when he started to eat, and an empty plate when it was finished. And another example is here, where we got like a picture of an apple that was kind of, I don't know, 20% eaten or something like that. So this was some early work with food images. I mean, now we do more complex interventions where we can put a lot of content into the app. We can use different languages. Here is an app, one of our recent ones that are also provided in Somali and Arabic. And we can also use videos and also audio files in Somali, for instance, to provide the content. So there's a lot of, I mean, things that have really happened since the early work. And in terms of what I kind of think about potential and challenges today is that I would kind of say that today, I mean, the sky is the limit in some way, because we can do a lot. We can collect a lot of data. This is a picture from a recent review talking about future directions for objective assessments of eating using wearable sensing technology. And it kind of illustrates that you can use different sensors. I mean, number 2 is, for instance, like a wearable camera where you photograph everything that is in front of you during the day. You can do it for a month. Number 3 illustrates more a sensor in the mouth that kind of analyze whether you're eating something salty or something sugary. And then, of course, you will end up with a lot of data on the food at the plate, but also the context when you eat. I mean, the environment around you, and a lot of things. So the sky is the limit. So I would say that this is a great potential. You can collect a lot of data. The challenge is that you will have a lot of data to process, and you can also wonder, what is the research question, and do you need all the data, or I mean, how should we kind of limit the data that we are collecting? So that's one potential, but also a bit of a challenge in that sense. And finally, my final slide, the other challenge and potential also is that there are a lot of other, I mean, tools and apps or whatever we are using out there. So how can we compete with everything else that's out there as researchers? So how can we kind of start developing, start evaluating, but also implement our tools? So that's something else to kind of think about as well. So this was a bit of a beginning to kind of get us going, hopefully. So now I will leave the floor to Brian, who will have the first presentation. So most welcome, Brian, and we look forward to your talk.
Hi, everyone. I'm very happy to be part of this seminar. My name is Brian Gutson, and I'm an associate professor in psychology at Karolinska Institutet. I will talk today about my research on internet-based psychological treatment for somatic disorders. My interest as a researcher has for quite a few years now been in how can we as psychologists use psychological methods to work with somatic disorders. And I will give the somatic, when I'm saying somatic disorders, I'm thinking about partly somatic disorders that have been traditionally denoted as functional, where it's patients present with a lot of symptoms, but actually it's not possible to find any organic cause for the symptoms. Examples of these are irritable bowel syndrome, IBS, fibromyalgia, chronic pain. But also in the last few years, my research group has focused on, in lack of a better word, real disorders, diseases like atrial fibrillation, where patients regularly have palpitations that that limit them and make them very preoccupied with their health, heart health. But this is not there's the cause for atrial fibrillation is not unknown like IBS and fibromyalgia, but it's faulty electric signaling in the heart. Anyway, what is characterizing for these disorders is that although the symptoms are often benign, they're not dangerous, they are associated with a large disability. And actually, if you look at these patients, there's also dyssynchrony between symptom levels and disability, meaning that some patients have very little symptoms but show a lot of disability, while other patients have more serious symptoms but show little disability. So there's something, it's not only the symptom level that decides how disabled you are. And you also see that in these patients, you have excessive healthcare seeking. So the patients seek a lot of healthcare, but they get very little or weak explanations for their symptoms in case of the functional somatic disorders like IBS and fibromyalgia. And also, and more importantly, this healthcare seeking leads to very little improvement in symptom burden. So the patients keep seeking treatment. And also you see that there are also, not in all patients, but it's common that patients present with some psychiatric comorbidities, anxiety, depression, or stress. And this is, I would say, especially pronounced in the functional somatic disorders, less so in atrial fibrillation. So we have developed a theory to try to explain why these patients become so preoccupied with their symptoms and seek a lot of healthcare. First of all, it's difficult for us humans not to interpret bodily symptoms as a signal for action. So if you feel that you need to pee, then you go to the bathroom. If you feel sleepy, then you go to bed, well, at least in the night. And if you feel pain, then you stop. You rest or take it easy, not to challenge the pain, or you don't move the body part that is in pain. So it's a natural for us to interpret bodily symptoms as a signal that our homeostasis is threatened in some way and needs to be restored, and then we take action to restore that homeostasis. And basically, I will skip the latter part and go directly to the model here. So basically, our body learns to discriminate symptoms based on how we react to them. So this is a model that we use to explain this to our patients. So we feel a bodily signal, and we perceive this signal. So the body sends a signal, and which we perceive. And if that perception leads to some type of behavior, we try to regulate the symptoms, that actually upregulates the perception of that symptoms. So meaning, for instance, when I'm leaving my apartment, if I feel a small need to go to the bathroom, if I react to that signal every time, then I will become more and more aware of whether I need to go to the bathroom or not when I leave my apartment. However, if I react to this symptom with some type of behavior that signals that the symptom is not important, I will downregulate my awareness of these symptoms. So if I leave my apartment, I feel I need to go to the bathroom, but I ignore that perception and I instead go to work, then I will become less aware of my need to go to the bathroom when I leave my apartment. And when I say go to the bathroom, I don't mean peeing, but I mean going to the bathroom to do number 2, which is a signal that we don't have to react on immediately. Most often, we can often wait a few hours before going to the bathroom to poo. And so that's the perception of symptoms gets increased every time we react on them. But also, if I have multiple negative experiences of symptoms, they will become associated with anxiety. So if I'm going on the bus to work, and I feel that I need to go to the bathroom, and actually I become afraid that I'm going to soil myself, that will, and which would be very painful experience on the bus, the need to go to the bathroom will become a signal for anxiety as well. And anxiety itself triggers bodily symptoms. So if I'm afraid of having somatic symptoms, those symptoms will trigger anxiety, which in turn leads to even more symptoms. And also, when I'm afraid of something, I become more and more aware of it. So actually, the brain's focus on symptoms that I'm afraid of increases. So that increases also the symptom perception. And most often, we regulate anxiety through avoidance and control behavior. So if I start avoiding going by bus to work, instead I take my car, which feels safer if I would get some urge to go to the bathroom, then I'm not actually exposing myself to the anxiety, which maintains the anxiety. So based on this processes, we have created this model, which where we have symptoms. When symptoms leads to behavior, that will increase the interoception of my awareness of my body, which in turn leads to more symptoms. If symptoms triggers anxiety, that also increases interoception, but also I regulate my anxiety through different types of avoidance and control behaviors, which then, of course, in turn leads to more interoception. But also anxiety can trigger symptoms. So basically, you end up with doing a lot of stuff that aims to regulate or control your symptoms, which actually in the long term just increases your awareness of symptoms and even your symptom levels. And also thoughts of, eventually patients don't even react only to symptoms, but they actually just react to thinking about symptoms. So if I come to think of, oh, maybe someone suggested we should go for a walk, and I'm like, well, maybe I'm going to have to go to the bathroom during that walk, so I will I say no. So just thinking about symptoms leads to avoidance and control behaviors. So we developed an internet-based psychological treatment for these somatic disorders, where we have a lot of emphasis on doing exposure exercises. So patients will do behaviors, eat some food, or even expose themselves to stressful situations. They will engage in physical activity, hard physical activity that triggers symptoms. And they will also engage in situations in which symptoms are unwanted. They will go to dinners or go on the bus or whatever situations that they usually avoid because they're afraid that they're going to get symptoms. And all these, the exposure decreases this conditioned anxiety to symptoms and situations. So basically, we're seeing this as a fear of symptoms that needs to be decreased through exposure to symptoms. And also the patients abandon different types of symptom control behaviors, such as resting, taking medications, eating specific diets, or planning their life around the symptoms. And we also include self-observation training. It's a type of mindfulness training, which is, you could say, mindfulness light, where patients learn to observe their body to detect symptoms that they would normally react to by avoidance and control behavior, but instead they behave more calmly in the presence of the symptoms. So they basically don't do anything when they feel that they have symptoms. Or they do whatever they're supposed to do. So yeah. So very simply, the model can be explained like this. Before they meet us, symptoms or thinking about symptoms leads to specific types of behaviors, and we tell them to stop that. And just to give a brief background on the internet-based psychological treatment format. So basically, patients, we write CBT manuals, cognitive behavioral therapy manuals, self-help manuals that we divide into chapters or modules. And during maybe a 10-week treatment, the patient will get access to 10 modules, one every week. And the patient, once a week, they will report homework exercises to their therapist. So they will report what they've done as part of the treatment, and the therapist, or often a CBT-trained psychologist, will give them feedback on their work with the homework exercises. Basically, you could say that you get the same treatment that you would get if you met with your psychologist. So we're imitating the content and actually the format of regular face-to-face therapy very much. It's just online instead. Here are some screenshots from the treatment platform that we use. Excuse me for it being in Swedish, but it's just to give you a sense. So this is an overview of the modules that the patient has access to, module 1, 2, 3, 4. The numbers are not right here. And when the patient clicks on a module, they read a self-help text that gives them psychoeducation about their disease, and also instructs them on how to do their behavior change. And at the end of each module, there's a homework report where they send in a report on how they have worked with the treatment. They answer some questions about the treatment content, and then they get feedback from their therapist. So here's like a chat view between a patient and a therapist. And patients will typically have communication with their therapist maybe once or twice a week. So it's not like a synchronous chat where the patient and the therapist sit in front of the computers at the same time, but rather it's more of an email-like system where the patient will send a message and will get response within 24 hours. So here's an example of one of the studies that we've made using this treatment model and also the online therapy format. So this is a study that I did 10 years ago for IBS. So we had 195 patients with IBS. They were randomized to do stress management, which is a sort of a treatment where the patients believe is often beneficial for them, but that actually often increases different types of avoidance and control behaviors. So patients in the stress management treatment, they learn that it's good to take it easy, to rest in response of symptoms, and also it's good to eat different types of, you shouldn't eat food that trigger symptoms, but you should instead eat good foods. And this treatment was then contrasted with this exposure-based CBT, which is actually quite the opposite to the stress management in many cases. So increased stress and eat a lot of bad symptom-triggering foods. And this graph shows the development of symptom severity during, so this is a 4-week baseline period where the red and stress exposure group and the blue stress group have the same symptom levels. And this is the 10-week treatment. And here you can see that the red exposure group show a larger decrease in symptoms than the stress management group. And 4 weeks after treatment, they have significantly less symptoms on average than the stress management group. And 6 months after completed treatment, the exposure group still shows less symptoms than the stress management group. And this is actually one of the few treatments that has shown superiority over an active control condition in a randomized controlled trial for IBS. So the exposure led to less symptoms, increased quality of life, and we can also see in mediation analysis that the advantage of exposure was mediated through reduced fear and avoidance. So development and challenges from 2010 to 2030. So when we began doing these studies in the mid 00-talet, I don't know how to say that in English, but between the years 0 and 10 in the 21st century. So no one used smartphones, and so they accessed the treatment or the platform from home on their desktop computer. But now the treatment can be accessed at any time because patients use smartphones now, so they can log into the treatment at any time. And the question is whether that is good or bad, because I feel like there's a lot of discussion going on within the online CBT research community. How should we capitalize on using smartphones? We need to add more fancy features to our treatments, possibility for patients to log every type of behavior that they're doing in real time, like Marie also discussed. So we're collecting a lot of data, or potentially collecting a lot of data. But the question is how can we use that data? And also, is it from a therapeutic standpoint good to allow the patient to give all this information? The first studies that did online treatment, then patients just got PDFs sent by email that told them how to work with the treatment. So that's really old school, and that actually worked very well. So what is the incremental value of the money and time that we're spending now on building fancy apps? In 2030, I'm quite sure that the development within machine learning and natural language processing will have progressed even further. So the question is, what consequences will that have for the therapist role? So will therapists be needed to give responses to patients' questions and homework reports? Or will there maybe be more a stepped care approach where some artificial intelligence will take care of most questions from the patients, and when it's inadequate, then the therapist will step in and give more personalized feedback? Yeah, actually, that's all from me.
Thank you, Ryan, for a very nice and interesting talk. I have a lot of questions, but I think we will save them for afterwards to kind of make sure that we are in time for the program. But thanks a lot. And it's interesting that you kind of raise the same potential and challenge as I did with this huge amount of data. I mean, so we need to kind of think about if we need it or not. And I mean, is it good or bad? Could be both.
Yeah. Yep.
But thanks a lot. So then I will welcome the next speaker, who is Anna Strömberg. So please, the floor is yours, Anna.
So thank you for the invitation to this seminar, and great presentation from Brian. I have lots of questions for you, so I hope we can have a discussion afterwards. I will take on a slightly different perspective, not specifically describing one research project or one research line, but more discuss with you and give you some of my thoughts on how are we going to work with patients, and in my case then also family caregivers that are part of my research program, to develop e-health interventions. What are the lessons that I have learned through working in this area, and what do I see as the future perspectives? And I'm a professor of nursing science at Linköping University, and together with Tini Jarsma, who will be the next presenter, I lead a research program called ICT for Self-Care. So information and communication technology to improve self-care in persons with chronic illness. My context have mainly been elderly patients with heart failure and other cardiovascular diseases, but I see the similarities and common ground with all kind of chronic diseases actually in what we're doing in our self-care interventions. So I don't know what happened to my headline here, but it should say not involving patients in research. It's like saying that you would do the patients as experts in the research is like saying that you would do very advanced statistical analysis without consulting a statistician. And I think that today all researchers and also all healthcare organizations are agreeing on that we need to have patients as partners in our work of developing research and care. But sometimes it's easier said than done. And that is very much what I'm going to focus my presentation on. So this is a little bit what's been my focus from 2000 and even before. I started my PhD in 1998, so it's been a while. And at that time, I had, together with my research group, an idea that we should develop computer-based education for elderly heart failure patients. And a lot of people were very skeptical because at that time, not a lot of people had computers, especially not the elderly. Just using the mouse was often a big challenge for an elderly person. So we developed a computer-based education. We used touchscreens, and we worked with patients to develop not the content, but to develop the technology and to test the feasibility of the technology. So that was a bit of a game changer at that time, and rather novel. Now it's really part of everything that we use. A lot of internet for gaining information about various health conditions. But at that time when we started off, there was no internet use and not so much computer use. So I think that's the challenge when working in an area where the technological development goes very, very rapid, and we have these early adopters that are often tech savvy people or younger people that start using new technology very early on, but we also have laggers that take on the technology quite late, and the digital divide with elderly persons being overrepresented there of not using using technology, but not to the same extent as the younger population. But what I learned from my very first project, that to never underestimate anyone and to never say never, that a lot of technology will actually work. And sometimes it does not work when you really think it would work. So I worked with various projects, very much focusing on education, the first 10 years of my research career. From 2010 until now, I worked a lot with telerehabilitation. I will present a teleyoga study that I have ongoing. Tini will present an exergame study that we've recently published. And I will also give you some examples on telemonitoring, which is also a field that evolved a long time ago in heart failure, but has not really reached its full potential, despite that we actually have a lot of research data. And what do I see around the corner? What are we working with right now and beyond? I will show you an example of a digital caregiver support that we just finalized, and another project that are more like in our mindset so far is that can we develop more virtual clinics for patients with chronic conditions? And my clinical background is in heart failure, and that's where I work. So that's what I want to work on in the future 10 years. So this is just a screenshot from this very first program that we developed, and that was actually translated into a number of different languages. This is the first version where we had an English and Swedish version, but it was used and translated in a number of countries because it filled a gap of educating patients in a different way. And what we actually saw was that those people with the lowest education actually liked the computer-based education the most, because they could repeat the information over and over again. They could select what they wanted to look at themselves. They didn't have a nurse or a physician sitting in front of them in a high speed delivering education that they were not maybe ready to receive. This is also just a screenshot from that specific program with very, very practical and a lot of animations, which was quite new at that time. So this is this is another approach that we have also just recently published, and it relates to telemonitoring in heart failure patients. And telemonitoring has been used over the years a lot in the heart failure area, and being discussed a lot. What information is useful to patients to have? And Brianne talked about symptoms, and there's a lot of like symptom monitoring, but also objective monitorings of blood pressure, of EKG, of biomarkers. But what is important for self-care in patients? What do they need to know? And here we're working with an Israeli group that are measuring lung impedance in the hospital. So we wanted to work with patients and caregivers to see if we could measure lung impedance at home, because if you've been recently hospitalized with acute heart failure, it's a big risk that you are rehospitalized within a month. And if you can detect a decreased lung impedance, that often is a measure that goes down up to 2 weeks before you actually have symptoms. So this could be an objective measure that you're going in the wrong direction. But if you have to come into this cardiologist every day to make the measures, or every week to make the measures, it's not very convenient. But if the caregiver can help the patient to put on the electrodes and do these measures. And in this project where we tested this in Israel, in Lithuania, and in Norway, we actually saw that both caregivers, family caregivers, and patients were able to do this, and they thought it was a good method, and that it gave information, and that could guide them to work in collaboration with their healthcare provider to change treatment. So this is an area where you have really inconclusive findings. Some studies are very positive, where you see that there's a huge effect on hospitalizations and quality of life by using telemonitoring, but there are also neutral studies. And especially if you have studies not involving the patients actively, but just sending in information to the healthcare provider, that can instead lead to a decrease in self-care, which is the opposite of what we want to achieve. So I will then give you an example of a study that we have developed together with patients, a telemonitoring study that we've developed together with, a tele-rehabilitation, sorry, a tele-yoga study. So yoga in elderly patients is also not as common as in the population as a whole. So we wanted to set out to see, is this an intervention that can actually work in elderly cardiovascular persons? So in the first step, we developed these online yoga sessions, and we developed an app to support yoga at home. And we tested it together with a patient organization. So they were with us during this development of the technology and testing of the first feasibility of the technology. Then we did a pilot study, and now we have an ongoing RCT, a randomized control trial, that we aim to include 300 persons doing tele-yoga. So this is just a screenshot of the app that we use. It's a very simple app that we developed together with our IT department. And initially, we had the idea that we would make a very advanced technology, that we would have the video conference system, the questionnaires for the study, the app, everything in the system. But it turned out both that it became very costly to do it, and also more complicated to implement for the patients. So we ended up with just making a very simple app and then using a commercial system. We actually used Zoom before Zoom became very popular during the pandemic. So this is just how one of the programs in the app looked like. And we also have a function in the app where we could see how much the app is used. And this is very important, of course, from a research perspective, to look at adherence to the specific intervention. This is what it looks like with the patients that are in the Zoom group. And this is also what we tested out very thoroughly with this initial group of patients from the patient organization, that we saw that they could use they all receive a tablet through the study with one icon for the Zoom and one icon for the app. So that's the only thing they see on the tablet, which is helpful to some patients that have not used the tablet before. So this is a new experience for some. Others are very used to using tablets, of course, but that we provide tablets for everyone to be inclusive, that everyone could be included in the study. And this is just another picture what it looks like. So the good thing about this technology intervention is that either though you're in your home, and that's crucial for some of these patients, because we did yoga studies where they had to travel to a yoga studio, and a lot of patients were too sick, so we had a lot of dropouts that they wanted to be in the intervention, but they could not really make it to the class. But now they can sit in their kitchen or in their living room and do the yoga, but they still have the experience of being in a group and using this already available technology, which is also, I think, for implementation purposes, an advantage, because whenever we develop our own technology, we can influence more what we need in the research projects, but it can be challenging to implement in clinical practice. So this is just another picture of how it looks for the patients. So as I said, this is an ongoing study, and it's a study where we started off with a lot of involvement of patients in the development, but then throughout the study, we're doing a more traditional randomized control trial, and I will come back to that. What are the pros and cons, and what are the future with that? So we had a very a co-design, very thorough development of the interventions with patients and also some caregivers that participated from this patient organizations. But then we moved on. So now we don't have, for example, a patient in the study group when we're conducting the traditional randomized control trial. Another ongoing study, or another study that we're just about to start, is a study where we use the platform of 1177. It's one part of 1177 called support and treatment. And in this interventions, we worked very closely with caregivers in determining the focus and the content of the program. We have expert then developing the material, but caregivers reviewed the material, and we hope that in this study we will be more inclusive throughout the design and data collection and data analysis to have the caregivers on board. So involving patients and caregivers, I'm from the nursing area, and in nursing we often are bragging about or patting ourselves on the shoulder that we're very good at being close to the patients, knowing about patients' experiences. But actually, the most that I learned of involving patients and caregivers in research, I learned from the technical faculty, from people in informatics and people in computer science, because they were much earlier off having the users involved in the whole process of developing new technology, testing new technology, and so that's really where I learned a lot about co-design of projects. And this is just a screenshot from what it looks like in this 1177 stöd och behandling, which is the word in Swedish. And we once again we see the advantage with working with with a standard platform that's available in all healthcare regions in Sweden, that it's very easy with implementation if we can show that this way of supporting caregivers is effective. So then we don't need to transfer a platform or a content to another standardized platform. But it's been a challenge to get into 1177. They were very reluctant initially to have people build a platform for research, not for clinical practice. So finally, then, how do we think about involving patients and caregivers in research already from wheat to bread, from the start to the end? And last year, I found a very interesting paper from Trisha Greenhalgh in the UK that's done a lot of work in looking at how do we co-design research with patients, how do we involve patients and the public in research. And in that paper, they actually have this figure showing that what we often use patients for in traditionally is to identify research projects, to maybe discuss design or content of an intervention. But to have patient organization, patients or other participants from the public in all steps of the research project process, that's much more challenging and unique and not so easy for us as researchers to pull off. But I think there is really the future of having patients in helping out to design studies, being part of developing research proposals and grant proposals, how to set up the different projects, but also then to analyze and interpret the data, to work with dissemination and implementation, and to then go back in this circle to initiate new research projects. So that was my last slide. Thank you.
Thank you, Anna, for a great talk as well. I have a lot of questions for you too, but let's save them a little bit. So now it's time for Tini. Are you here, Tini? Or
yeah,
yes,
I'm here.
Yes, welcome. So this
Yes,
is our third
thank
speaker,
you.
And the floor is yours.
Thank you. I'll just see one more time. So hi everybody, Tini Jarsma is my name, and I'm very excited to be here today, and I'm also excited to be invited by Marie Lööf because we will be the first leaders of the strategic area styrkeområde in Swedish, e-health. So I hope you will all be part of that soon. And I think this is great that we can speak together about e-health in all kind of ways. And I think already now when we have these three presentations, it's so interesting to see what we all do in e-health, and it's all under one umbrella. So I will have a little different again intervention to discuss and also some challenges we faced. So my presentation is called Alternative Ways of Exercising, and the subtitle is Exergaming for Cardiac Patients. And we work with two studies. It's called the Heart Failure We and the Heart X, with the same logo. So and as you can see, actually, it is a very like all e-health, but it's a very timely subject. And I just yesterday Googled a little around and saw that like exergaming now in this whole COVID-19 pandemic has been also recognized. It's interesting for home-based rehabilitation, but also coping with anxiety, etc. So that is very timely also. And I was just thinking, before we start, you might even think, what the hell is an exergame? So, but maybe some of you already play it like every day. So just to get a little idea about my public here, I would like to share a poll, which you then can answer. So do you have an exergame in your house? Yes, we have Nintendo Wii. Yes, we have Xbox. Yes, we have a PlayStation. No, I don't have it, or I have no idea what an exergame is, which you probably know by the answers, but anyway. So if you can answer the poll, then I have some idea later. And we go for a response rate of 80%. So Emily, you can see how many.
74% right now.
Oh, I can do myself one. Then I add up.
Okay, now we'll try to share it as well with you so you can see it.
Yeah. So the most 4% does not know what it is, but you will learn soon. And then 50% does not have it, and several have like either a Nintendo Wii, Xbox, or PlayStation. It's in the house. It does not say, of course, that you play it, but anyway. So thank you so much. So I know a little bit my my crowd. So now we'll just resume that. So if your poll is still on the screen, you can just click close poll and then it will go away. So what is an exergame? An exergame is the playing of video games that requires rigorous physical exercise and intended as workout. So I often say during conference, it's not playing Candy Crush or a Sudoku on your telephone. That's not an exergame. You have to really do something. It involves technology-driven game playing, and it uses also technology that tracks the body movement and then projects it back to the TV or the screen. And it's also called exertainment, active gaming, serious gaming. And here in this slide below, you can see an enthusiastic guy bowling. So you can see his bowling movement is then produced to a ball going, and then it will also register what he does. And here you can also have this woman on the bike, you have extra biking, etc. So we actually had done this study. It's called Heart Failure Wii, and it also refers already, of course, to the game we used, Nintendo Wii. But we do not say that we only tested Wii. We're interested in the concept of exergaming. So that's already one challenge, of course. Like if you have one thing, one app, or in our game, like one platform, are you testing the concept or are you testing the platform? So this is our team, a big team, and international collaboration also. And this is our proud slide that we presented our heart failure Wii study trials in our results in a late-breaking clinical trial in the ESC conference in Barcelona, the time we could still travel. And we have a lot of grants doing this study. And just to show you that we like Anna said, showed like different phases. We also had different publications from that study. That this is the trial design. Then we have our main results. But we also did some qualitative work, really to ask the patients, like, what did they think? Did they like it? Did they play or not, etc. And then we had a workshop actually 2 years ago with a big international group who came to Norrköping, and we talked about, should we have a new game or should we use these standard platforms? That's also, of course, a discussion point. Should you use off-the-shelf products or should you make something yourself? So we have different experiences in that. So I would like you to share you one little result. I hope it goes. Oh, sorry. Just see if I click.
The daily routine.
Ja, det betyder ju att vi får lite motion i början. Och erfara, till exempel vi träffar någon och hittar sig jag vill inte spela idag. Då säger jag, det är klart vi ska spela. Och då kör vi.
This activity means that Ingvar can keep working.
Och vi är rätt med på så mycket innan vi jobbar där. Att för att klara av det bussfight gör det man själv.
Jag märker när vi går från garaget till jobbet. När vi inte har spelat någon period så vill jag gärna stanna. Jag går ungefär en 10 minuter. Då ska vi se. När jag börjar spela så går han. Så det är lite motion här uppe.
So this is our film star, movie star patient from Norrköping. So, and Mona says that it does something. Of course, it's a little bit, we got a lot of criticism that you can also play an exergame in the chair and do bowling like this, like my children do, or tennis. Then it's not really exercise. But if you do it right, and most of our patients are not there to cheat, but they want to feel better, they do it right, you can actually get good exercise values, and you really spend some metabolic equivalence of the task. So what is the idea behind it to get exergaming into health? So this is sort of a model we try to use at Exergaming. It's a challenge. It does really something you have to perform. It gives feedback. It gives enjoyment to most, not all, and also convenience because you have it in the house. You don't need to travel. You can play it whenever you want, etc. All these things should lead to increased motivation, improved physical activity, and improved self-efficacy. So the idea that they really can do it, which should, we theorize that it should lead to better behavior. So more workouts, new habits, adherence to exercise, and increase in all daily physical activities, and that would lead to improved exercise capacity and health. So that's the idea how it would work. So not only by playing, but also by feeling better. So what we did is in our study, we did a sort of straightforward randomized control trial where people were randomized to an exergame or to a control group, and the control group got actually an exercise advice, and then we followed them for 12 months. So we had a one-to-run randomization. I just came out just before now from the scientific methodology course where I learned them how to write this. So I did a very concise writing here. One randomization to motivational support or structured access to an exergame. And we assessed outcome 6-minute walk test, which was the primary endpoint in the study. We had several centers in 3 continents, so that was cool to do. And the intervention group got like this game computer. They got an introduction lesson in a group in either the hospital or in a rehab center. Then one of our instructors, we paid an instructor to go home to the patient to install it on their TV and also give them instructions. And they got this personalized activity gaming advice. And then we called them at 2, 4, 8, and 12 weeks. And the game instructor could be called for troubleshooting for these 3 active months if the device did not work or whatever. And the control group, they got the personalized activity advice and the motivational follow-up calls also at the same intervals. So we did the study, and I will not bore you with all the results, but just to show you, we had several different outcomes, patient outcomes, but we also looked at costs and patient experiences in this RCT. And we had patients who are a little older, but this is our group of heart failure patients. We managed to include 30% of women, which in our heart failure research is also not easy. And we also, this is also nice that we actually looked if people had grandchildren, because from the pilot we saw that really influenced their playing. So I will not go through all the results because that will take too much time, but just some lessons learned that we found that this general exergame was not enough to improve outcomes for all patients. So we had some, good patients and some patients who increased and decreased, like in a lot of neutral studies. But it was not like this general exergame was not enough. Some patients really liked to play and others did not, like probably all of our interventions. And not everybody played as instructed. Some played much more and some played not at all. And some people not even took the whole thing out of the box. So that's also interesting. Patients with certain comorbidities might benefit less. So if people had comorbid stroke, they benefited less. And of course, what we all people online here know that we need to tailor. We cannot just give them a game and say, okay, go on and play. We did not see a lot of technical problems or fears. It was not a reason for not being in the study. So we documented that well, but it was also not a reason for dropout, etc., or decline. So now we have planned a new Exergame study where we will all use all the lessons learned. So we will have tailoring, we will have an Exergame coach, we will have a social network helping people to play, and we will do much more tailoring of our group, that we really give it to the people who need it and not the people who already did a lot of exercise, which we had in our group and did not really benefit from this Exergaming. So we are proceeding, and we hope to get funding, actually. And one more little thing I wanted to add is that what we also did is we started a virtual bowling competition with patients from Riksvereniging Jet Loen, where we had two teams. The idea was make Norrköping game against Linköping, and then we wanted to have it in the whole Sweden. We are now in the states that Linköping and Norrköping play together because they don't want to compete. But as long as they can come together. So before COVID, they came and played, which was really nice. So to my last slide, let the games begin. I think it's really interesting to study serious gaming as a way of e-health to improve health. But of course, we have a lot of challenges. What is the optimal dose? Should we, as I said, should we take the game off the shelf, or should we develop? It's hard to keep up with developments, and I think we all have that. Like when we started the study, or halfway the study, Nintendo Wii decided to stop selling Nintendo Wiis. So there we were. So that's, things develop so quickly. So, and of course, what we all have. What should the control group have? Should they secretly buy? They secretly buy Wiis or not? Or should they have a motivation advice, etc.? So that was my presentation. Very happy to discuss.
So thanks a lot. Again, a very nice presentation. Before I think I just have a few questions that I will kind of start with. I'm sure everyone has a lot of questions as well, but I will just share my screen to see.